with here I wanted to give you this opportunity here to share with you an introduction of the imaging anatomy and the clinical implications of imaging of the skull base. Now, skull base is an important aspect of imaging of the head and neck. Can you see the screen?
Yes, sir. Yes, sir. Perfect.
All right. So, so the imaging anatomy of the skull base is important to understand the integral connection between the head and neck and the intracranial compartments. And as a disclosure, I have no financial disclosures, and I'm grateful to my colleagues, Dr. Lobo, Dr. Mukherjee, and Dr. Srinivasan, to embellish this lecture with their expertise and their contributions in both in the literature as for this study. So the objective of this lecture is to present an overview of the concepts of imaging of the skull base and to just give an introduction to the surgical approaches and the clinical implications of what we see on images. And then we'll discuss with end with some representative cases which I had shared with you earlier. So the overview of the presentation would be on the definition, on the anatomy, the pathologies, and any specific information regarding aspects of intracranial extension, intradural and extradural structures and structural involvement, and also certain critical aspects of involvement of vital structures in the central skull base and perineural extensions. So just to briefly recapitulate, the skull base predominantly develops from the cartilaginous precursor of the chondrocranium, and the frontal and nasal bones are the only two components which are of membranous bone ossification, and the chondrocranial components include the majority of the components of the sphenoid bone, the occipital bone, and portions of the orbit, as well as the junction between the occipital bone as well as the sphenoid bone. There are certain primordial neural foramina which are important because those allow for egress of the neural elements from the brain to the head and neck, and they form an important conduit for communication of pathologies from the head and neck to the intracranial compartments. So it's a pretty dynamic assessment, and I hope that we'll be able to cover most of the aspects of that particular dynamic assessment. So the imaging modalities for the studies are MRI and CT, and MRI scores as far as the soft tissue component and osseous infiltration goes, and the CT involvement, CT is primarily involved to look for bony involvement and for certain patterns of permeative and erosive destruction together with either expansion or remodeling. So one can have a very good assessment of the pathology just by looking at and assessing the type of pathology and the morphological features of what the lesion is trying to do to the skull base. Just to recapitulate and just to have a very broad pathological basis of disease for the CNS, we know that the CNS contains only neural elements, osseous elements, fluid like CSF, and connective tissue elements such as blood vessels and muscles and fatty tissue. So you can imagine the majority of the pathologies will be restricted to these cell lines. And if you have that in mind and you know the anatomy very well, you can easily trace out the pathology based on very typical radiological features of those lesions. So this forms the basis. The entire basis of head and neck is that's the crux of this approach to looking at the diagnosis of head and neck lesions on imaging. So the CT techniques are now very well established, and we can do coronal and axial imaging. But now with the advent of helical scans, you can get multiplanar reconstructions and 3D reiterations of the skull base as well as the soft tissues. In the MR, we can use standard head neck coils, but you can have now specialized multi-channel coils to image both the vascular and the soft tissue structures as well as the osseous structures. And some of the coils are so designed to have a very extensive coverage from to up to at least the lower portion of the neck if used properly. So we can have a wide armamentarium of imaging modalities now to help us in looking at the skull base. Now, broadly speaking, the skull base is divided into three major components, which actually define the intracranial compartments: the anterior cranial fossa, which is limited from the frontal bone to the sphenoid ridge; the middle cranial fossa, which extends from the sphenoid ridge to the petrous ridge; and the posterior cranial fossa is bridged by the petrous bones and the occipital bones posteriorly. By definition, the anterior skull base is limited by the posterior wall of the frontal sinus anteriorly and the anterior surface of the sella posteriorly. It is of importance to know that the orbits and paranasal sinuses are not components of the anterior skull base. However, the integral components of the skull base include the cribriform plate which forms this roof of the ethmoid sinus, and the orbital plate of the frontal bone, which actually forms the roof of the orbit, and the planum sphenoidale and the lesser wing of the sphenoid bone, which forms the roof and the side walls of the sphenoid sinus. Together with the frontal crest and crista gelli, which are important landmarks for evaluation of the contents of the skull base. So just imagine that these bony components actually are intimately related to the paranasal sinuses and orbits, and hence any pathologies from those structures can invade the anterior cranial fossa and cause symptoms to the patient. Amongst the foramen, which are important for the anterior skull base, one should remember the foramen cecum, which actually is a primordial component foramina, and it actually houses the emissary vein as just anterior to the crista gelli. The anterior and posterior ethmoid foramina, which are at the extent of the ethmoid sinuses, are the important conduits for important anterior and posterior ethmoidal arteries. And there are multiple foramina of the cribriform plate, which actually are the egress of the olfactory nerves in the mucosa of the superior meatus of the nasal cavity. Here are some examples of the variations one can encounter. And just to recapitulate the structures, the cribriform plate is a vertically oriented osseous structure, which sometimes can be pneumatized. And on either side of the cribriform plate, we have the depressions of the olfactory grooves. And at the most dependent portions of the olfactory grooves are the foramina for the olfactory nerves in the cribriform plate. And the roof of the ethmoid sinus more laterally is called the fovea ethmoidalis. So remember that the anterior and posterior ethmoidal foramina are not usually visualized on routine evaluation for the skull base or paranasal sinuses because they are so small. However, the exact position of the ethmoid roof is important for us because of the attachment of several other structures, like the plates of the uncinate process and the grand lamella, which is the connection of the middle turbinate to the anterior skull base. So different type of classifications and different types of measurements have been made just to assess the depth of the olfactory groove, because as you can see, it's intimately connected to the insertion of the middle terminate. So any functional endoscopic surgical procedures, if your one is not careful, you can just pull at these structures and then cause damage to the cribriform plate, and hence lead to defects in the anterior skull base, which are commonplace causes for CSF rhinorrhea or torrential hemorrhage in those instances where the anatomy is kind of neglected and not looked into. Various classifications have been described in the literature to assess the depth of the olfactory groove. But then the entire imaging strategy develops on looking at both the CT as well as the MR evaluation. So here is an example of how we actually assess for those. One can see the intact appearance of the fovea ethmoidalis and the cribriform plate in this section. The complementary T1 weighted sequence on the MRI will show you the gyrus rectus on either side reaching up to the depth of the cribriform plate, and the T2 weighted sequence will show you the olfactory apparatus separated from the gyrus rectus by a plane of CSF. So once we have this information, we can assess for any pathologies if we have the normal anatomy in your mind's eye. The cribriform, the crista galla itself has got several variations, and sometimes it is like a very broad, non-pneumatized piece of bone with very shallow appearing olfactory grooves on either side. Sometimes it just appears as a thin spicule of bone, and it is very difficult to identify. And the complementary images also then would show variations in the depths of and difficulty in assessment of the olfactory apparatus in these individuals. So these are the two examples which actually show you the variations and how you can sort of complement each other by using CT and MRI to study the structures in the inferior frontal lobe. As I mentioned to you earlier, the majority of the lesions which involve the anterior cranial fossa or the anterior skull base arise from the paranasal sinuses, orbits, the lacrimal glands, or the forehead. And one of the classic examples which is often stated is the Pott's puppy tumor, which actually is an inflammatory condition of the frontal sinus, which actually results in formation of a purulent abscess or purulent collection in the soft tissues of the forehead. The CT and the soft tissue windows will show you the soft tissue component. The osseous destruction in this partially pneumatized frontal sinus is seen on the bone window of the CT. However, the MRI offers us a more comprehensive look as to what is happening in this patient. For example, one can see the changes in the marrow spaces of the non-monetized portion of the bone. We can also see the erosions of the frontal bone. We can see the components of the soft tissue or the purulent material in the region of the forehead. And also here we can see there's enhancement of the dural reflections of the frontal lobe, which indicate that the bone is actually breached there. And most likely there are a number of emissary veins which occur in this location, which are unnamed, and the infection may travel through the channels of the emissary vein to involve the intracranial structures. So once we have this sort of a comprehensive picture, we can then modulate our treatment therapy as well, because once the dura is involved, the infections from the paranasal sinuses has traveled into the intracranial compartment. And then from the CSF pathways, it can disseminate to involve the portions of the rest of the skull base as well as the spinal canal. So it's important to realize how the pathology actually influences the management. Moreover, some instances would be helpful to make a diagnosis in the acute phase itself, where we can see that there is this patient who came with a history of trauma in the remote past, and the patient then had CSF rhinorrhea. And once we can see for ourselves that on the CT, on the bone and soft tissue windows, there is this area of encephalomalacia of the frontal lobe, and also some soft tissue material which is non-dependent protruding through the defect, possibly representing a traumatic encephalocele. And in this patient who was scanned in the prone position, one can see the dependent fluid levels in the maxillary sinuses, which suggests that there is an active CSF leak. And this then entails an emergent management for this patient who has this active CSF rhinorrhea. Once we have the anatomy in place, we can then plan out our surgical approaches as well. There are two major approaches here for the anterior fossa. One is the cranial approach, where we do a bifrontal craniectomy by using an incision for taking out the facial soft tissues over the patient's face and exposing the frontal bones, and then removing the frontal bone and exposing the frontal lobes, and then lifting the frontal lobes to assess the anterior skull base, especially useful in patients who have got large pituitary masses or large tumors such as a meningioma attached to the anterior fossa. The facial approach is through the naso-ethmoidal route, and where we can see we can make an incision to directly observe the contents of the ethmoid sinus, and also portions of the medial wall of the medial wall of the maxillary sinus has been removed, and one can also have an access into the orbits as well, including portions of the lacrimal sac and the lacrimal fossa. So this is, with knowing these approaches, one can also then interpret the post-operative imagings of these patients as well, and anticipate the post-operative sequela as well as complications by knowing the route in which these tumors are approached. Moving slightly more posteriorly to the anterior cranial fossa, when we start reaching the middle cranial fossa, we can see the landmarks of the sphenoid bone in the coronal plane, which are important. And I want to reiterate that the sphenoid bone itself looks like a bird in flight, and the greater wing of the sphenoid bone are the wingspan of the bird, and the talons of this eagle are represented by the pterygoid plates and the pterygoid fossa between them. The major features of the coronal aspect of looking at the anterior wall of the middle cranial fossa and the posterior wall of the anterior cranial fossa lies in recognizing the superior orbital fissure and the inferior orbital fissure, and the expected location of the pterygopalatine fossa in the coronal view. This is important so that you can understand the anatomy of how the structures are arrayed there, and how intimately both the foramina or sometimes called the fissure are actually related to each other as far as the egress of structures from the intracranial compartments to the orbits and to the rest of the inferior portions of the maxillary region of the face is arrayed. And here is the same patient showing how the changes appear. Although this appears to be a very confusing sort of a picture to the novice, just remember to trace out the planum sphenoidale and then come back up again against the posterior portion of the orbis to see the superior and inferior orbital fissure and the expected location of the pterygopalatine fossa. Coming then seamlessly to involve to study about the middle cranial fossa. It's a bit butterfly-shaped depression, and the posterior margin of the lesser wing of the sphenoid bone, as well as the anterior clinoid process and the anterior margin of the chiasmatic sulcus or the chiasmatic groove are the important landmarks for the middle portion of the middle cranial fossa. In the posterior aspect, we have the entire petrous ridge and the smooth surface of the petrous ridge here, and portion of the dorsum celli here, which is the projecting plate of bone which forms the posterior wall of the sphenoid sinus. And in the lateral aspect, we have the squamous portions of the temporal bone as well as the greater wing of the sphenoid bone here. So if you recapitulate your anatomy, the central skull base becomes a little important because of the critical neural as well as endocrine structures which are located in this part of the intracranial compartment. Classical teaching is that the middle cranial fossa is actually divided into a midline sagittal compartment and two parasagittal compartments. Sorry, and the far lateral compartment. And each of them have got typical typical surgical approaches to for which the neuroradiologist is actually called upon to define and to aid in the pre-surgical evaluation of these patients. So coming to the central skull base, or which is the central portion of the middle cranial fossa, this portion is important because it is bounded by the lesser wing of the sphenoid bone and contains the sella turcica, which is the central portion, and the important structure therein is the pituitary gland. Then we have the anterior and posterior clinoid process. Posterior clinoid process. The anterior clinoid process is always a well-defined structure, but the posterior clinoid process is always very variable. So we don't really ever comment upon that. But the anterior clinoid process forms a very important landmark here, because just medial to the anterior clinoid process is the optic foramen, through which the optic nerve egresses out of the comes in from the orbit into the intracranial compartment. The other important landmark is the tuberculum celli, which is a slight bump along the anterior surface of the sella. Usually you can see this in the high resolution sagittal reconstructions for the skull base. And the chiasmatic sulcus is another important landmark which offers as a groove, which I showed you in the previous slide. Just as a reminder, these are actually anatomic landmarks, and they are important in as much as to localize the lesions which are arising from the sella or outside of the sella. Although the chiasmatic sulcus appears to be along the anterior margin of the sella, the optic chiasm is never usually aligned with that sulcus, and that in that way it becomes sort of a misnomer. The optic chiasm actually hangs in the supracellular cistern, and it's kind of firmly attached anteriorly to the it's a firm continuation from the optic nerves anteriorly and the optic tracts posteriorly. So one can imagine that the time-long conventions of naming structures has become so ingrained in us that we just think that in our mind's eye that they may be related to the actual structures which are in the vicinity of that nomenclature. So here are a certain important foramina which are the bane for all examinees and examiners. The yellow arrow points to the optic canal, which is the path for the optic nerve. The ophthalmic artery and the sympathetic fibers of the choroid plexus, they also are in close vicinity of this foramen. The foramen lies medial to the anterior clinoid process, and the anterior clinoid process forms an important landmark to distinguish this optic canal from the superior orbital fissure. The superior orbital fissure itself has important contents. It has the cranial nerves 3, 4, and 6 as they egress from the cavernous sinus and enter the orbits, and it has also got branches of the first division of the fifth cranial nerve as it supplies the interior of the orbital structures. Then there are several sympathetic routes which actually emanate from the ciliary ganglion, which are important components to the contents of that fissure. In the parasagittal compartment, the importance of looking at the petroclival synchondrosis and the foramen lacerum, which lies just lateral to the carotid canal, is of utmost importance. The medial aspect of the greater wing of the sphenoid bone also forms the boundary of this parasagittal component, which is Important because it contains the cavernous sinus, and in the cavernous sinus uh, uh, are the cranial nerves 3, 6, 4, and the 2 divisions of the trigeminal nerve together with the carotid siphon. So the egress of the cavernous sinus is into the inferior orbital fissure, and the inferior orbital fissure is a direct continuation with the superior orbital fissure on the contiguous axial sections taken through the skull base. The contents of the inferior orbital fissure include the pterygopalatine ganglion, the inferior ophthalmic vein, and in the coronal plane, the inferior orbital fissure actually leads into the shallow pterygopalatine fossa. The other important foramen which occurs in the same plane or slightly below the level of the inferior orbital fissure is the foramen rotundum, which contains the second division of the fifth cranial nerve. These are well-formed and well-corticated channels which extend from the skull base to the exterior to the inferior part of the maxillofacial skeleton. This is another representation of the foramen rotundum seen on the axial sections. And you can see that it is well corticated and lies just lateral to the wall of the sella in the same patient. And also note that it is related to the Vidian canal, which occurs inferiorly and medially to this foramen. This area, which you see here, I have deliberately chosen this just to make sure that you know that the bone itself is sometimes having a heterogeneous attenuation, and one has to be very careful into making your choice into looking at which is actually the true foramen and which is not a true foramen, but actually looking at the which represents the heterogeneity of the marrow spaces of the sphenoid body of the sphenoid bone. Just remember the ideal situation would be that all foramen have got both a coronal as well as a sagittal counterpart, and you can see them if you put in and align all the images together. The Vidian canal itself is a very narrow channel, and it contains the Vidian artery and the Vidian nerve, and it reaches into the pterygopalatine fossa, which is the great junction for several neural structures. Here also are the major foramina of the which egress the third division of the fifth cranial nerve, which is the foramen ovale, and inferior and posterior to the foramen ovale is the foramen spinosum, which contains the middle meningeal artery and the meningeal branch of the mandibular nerve. This is a composite picture which shows you three major areas of interest in the middle, the parasagittal and central compartments of the skull base. They include the optic canal, the foramen rotundum, and the Vidian canal. Here it is slightly larger than or nearly equal in size to the foramen rotundum. The foramen ovale is more posteriorly located and appears as a very well-defined defect on the sagittal images. On the MR, however, the fat contained around the neural structures offers us a very good idea as to where the nerves are located, and one can see them very clearly if you have a clear eye about what to expect in looking at the foramen ovale and its contents. And we can see in this patient, the same patient, that the egress of the third division of the nerve between the pterygoid musculature is very clearly defined on the coronal images as well. This composite diagram imprints upon the mind's eye the impression about the three major foramina which transmit the three major divisions of the trigeminal nerve, which are important aspects for perineural extension. They include the superior orbital fissure for the first division, the foramen rotundum for the second division, and the foramen ovale for the third division of the trigeminal nerve. The pterygopalatine fossa is a fat-containing area here. One can see the In this non-contrast imaging, you can see the fat outlining the neural elements, including the pterygopalatine ganglion in this location. Any enhancement on this area on the fat saturated post-contrast T1 images would let us know that there is an infiltration there and there is a potential source for further extension along the divisions of the trigeminal nerve in case of malignancies of the head and neck. That is the representation of the fat sat, the fat preserved fat in the T2 weighted sequence in the same patient. So here are the images of how the nerves look in the foramen rotundum and in the Vidian canal, and you can see that in the pre-contrast and post-contrast images, there's only very little enhancement in the perineural region, as opposed to the more thick and prominent enhancement, which we'll see later when these are actually involved in pathologies. This again is an example of an enhancement seen in the region of the foramen rotundum as it appears as a channel showing the non-enhancing portion of the tumor of the nerve within the foramen here. Similarly, the foramen ovale appears as a defect, and we can see the third division of the trigeminal nerve coming through that defect and going into the towards the pterygoid fossa, pterygoid musculature. Several normal variants occur, and they have been described in the literature, and one of the most common ones is the craniopharyngeal duct. It's a rare condition, but should be mentioned because it often acts as a pathology and is mistaken as a pathology. In the lateral compartment, the landmarks include the Meckel's caves in the greater wing of the sphenoid bone, and also the osseous elements. They form what is called the sphenoid triangle, which is the confluence of the squamous portion of the pterygoid of the temporal bone, as well as the greater wing of the sphenoid bone, together with elements of the zygomatic bone, which forms the eponymous sphenoid triangle. And also one can then wind off by looking at the temporomandibular joints, which occur and are often overlooked. Several surgical approaches are there for the anterior, middle, and posterior cranial fossa. For the middle cranial fossa, we can have the transsphenoidal approach. There is a transmastoid approach where the incision is made behind the auricle, and then the mastoid cortex is exposed for access of the lateral aspect of the middle cranial fossa. And we have a frontotemporal approach where the frontal lobe as well as the portion of the temporal lobe are lifted up for assessment for access of the trigeminal ganglion, and also portions of the labyrinthine structures and the geniculate ganglion. For the posterior cranial fossa, I shall skip over it because it's a very common, several common structures that occur here. And for the sake of brevity, just have to revise over looking at the carotid canal and the jugular foramen, and just to know that the jugular foramen has got two components to it: the pars nervosa, which has only one nerve, and the pars vascularitis, which has got two nerves, and the jugular bulb. So in the pars nervosa, we have the 9th cranial nerve, and with the pars vascularis, we have the 10th and 11th cranial nerves. Next is the all-important internal auditory canal, where we can see the 7th and 8th cranial nerve. This is, everyone can recognize it. But just to make you aware that the cochlear canal has to be identified in every other patient, because that is the entry of the cochlear nerve into the to the cochlea, and also identify on high resolution CT scans the superior and inferior vestibular canals for the which house the two divisions of the vestibular nerve. The hypoglossal canal is a very fairly wide channel which occurs at the edge of the clivus. And one can see the hook-like structure of the jugular spine, which actually bounds the canal here. And the hypoglossal nerve is one of the components which are there, which we can see in cases of perineural um, uh, perineural metastatic involvement, and also in cases of other meningeal pathologies like extensive neurosarcoidosis, where the perineurium enhances. Oftentimes, trainees get confused about the vestibular aqueduct, which is shown here as a shallow channel which runs along the posterior aspect of the petrous ridge, and it parallels the posterior semicircular canal. So this is just a representation of a vestibular aqueduct, which I needed to reinforce, and for all of you to recognize when you do the next assessment. And the approach to the posterior canal fossa is through a standard suboccipital route, and important structures such as the transverse sinus and the torcular urophili are important. And that's the reason why oftentimes the neurosurgeons or the head and neck surgeons will ask you to do a assessment of the dural venous sinuses, just to look for the position so that they don't injure these structures. And also we need to go back and check on certain infiltrating pathologies which can involve these major venous channels to the intracranial circulation. Apart from just the internal architecture of the skull base, is the external architecture also is important, because of the various spaces of the head and neck which are in direct contact with the skull base, which include the masticator space, because the trigeminal nerve coming out, the third division coming out through the foramen ovale will go and sit into the pterygoid musculature, between the pterygoid musculature. The parotid space is important because it is the seventh cranial nerve which extends through the stylomastoid foramen, which is important because that is another area where through which the pathology can egress into the intracranial compartments. The carotid space is intimately related to the carotid artery, and it is involved or seen in several conditions, as is the jugular foramen, which forms one of the other components of the carotid space. And of course, the pharyngeal mucosal space is the area which is directly involved with the basis sphenoid and the clivus, and any pathologies of either of the two structures, two compartments of um, can have implications for clinical diagnosis. I'm just going back again to let you reflect upon the staging of the head and neck tumors, just in case if your department does the staging. Just to remember that in the previous edition of the AJCC staging, the invasion of the medial wall and of the orbits, maxillary sinus and palate, and the cribriform plate constituted T3 stage of the tumor, and any extension into the anterior fossa was a T4 tumor. So the degree of reciprocality of radiotherapy and extensive mutilating surgery depends upon the accurate staging. So one has to be very one has to look at these particular areas for accurate staging of the tumors. These are implications for looking at and doing the surgeries for a complete maxillectomy together with excenteration of the orbit, because that is the crux of defining stage 3 and stage 4. Here you can see that this is a CT, this is an MR evaluation with and without contrast. And if this non-fat sac evaluation, is important to note that there's no tumor invasion of the fat surrounding the extraocular musculature of this tumor, which was seen on clinical evaluation. And one can see that that hypointense city of the bone is from the cribriform plate is also lost here, and there's an edge to the enhancement, and the edge of the fat contained within the periorbita here is important. So both the pre-contrast fat fat-containing T1 images and the post-contrast fat-containing images become very important for evaluation. So fat-sat and pre-fat-sat images, both of them are important for accurate estimation of the extension of the lesion from the paranasal sinuses to the orbit or to the intracranial compartments. The 2018 AJCC classification now again hasn't really changed much in over a period of time, and you can just see that there is now there are instead of two stage 4, we have 3 stage 4 type of tumors. And so moderately advanced to very advanced local disease is important. So again, the definition of that moderately advanced disease is limited to evaluation of the orbits and the cribriform plate. So hence it becomes very important. So I've just chosen this one type of malignancy of the head and neck just to reiterate how important it becomes for us to evaluate the entirety of the skull base. So this is a older slide which shows the Kaplan-Meier survival curves compared with no involvement of the bone, dura, and brain of the anterior fossa for head and neck carcinomas, and one can imagine that there's a progressive decrease in the overall survival of these patients with progressive involvement of the intracranial structures from dura to brain and to bone. Here is a classic example where it is kind of very difficult for us to know whether or not the bone actually is breached and the dura is also involved. Notice that there is a clear space between the CSF space between the enhancing portion of the dura. So the lesion perhaps has not reached the brain here. But if you notice very carefully here in this slide, you can see that there is involvement of the brain parenchyma as a sliver of enhancement. So one has to be very careful and then note these changes which are present, and then make sure that the brain is not involved for the evaluation for this patient. So multiplanar evaluation of the post-contrast fat-sat T1 weighted images then becomes a little more important. Here is a clear-cut involvement of the dural reflections here in a patient who had previously been operated for ethmoidal cell carcinomas, ethmoid sinus carcinomas. So you can see that there is no doubt about that the dural invasion has occurred. And also make sure that these spiculated areas of enhancement which you see are actually leptomeningeal enhancement, and then sort of increases the chance that this patient will have a poorer prognosis. So early evaluation of these subtle changes are important as well. So the limitations of the T1 weighted sequences and the T2 weighted sequences are actually shown in this study, where the T1 weighted sequence may show a featureless brain. However, the extensive edema around the tumor, which actually is an extension from the ethmoid sinus, will let you know that the extent of the involvement of the brain is far more than what is actually expected. Remember that the flare or T2 weighted hyperintense signals in some instances may represent an active edge of the tumor, although there may be no enhancing component to these tumors as well. Another important aspect of imaging is also involvement of the carotid sheath structures, because if there is near total involvement of the carotid artery, the tumor in the head and neck becomes nearly inoperable, even though that the further circulation at the skull base may be patent. Perineural extension is shown here very nicely in a very graphic description, demonstration of a tumor in the maxillary region, involvement of the pterygopalatine fossa, as well as the foramen rotundum and the cavernous portion and the cavernous sinus here. So we can see that in one big sweep, we can see the major areas of the skull base which are involved, together with the infiltrative aggressive changes in the marrow spaces of the basis sphenoid. Evaluation of the normal anatomy is important because we can see the absence of the carotid canal here and the presence of the carotid canal there. So we can make sure that we don't miss out on the major anomalies which can be missed on a cursory evaluation. Again, here another important thing is to look for even the smallest of the neural foramina, just to make sure that they are present, and I've demonstrated here absence of the foramen spinosum. In the pediatric head and neck, make sure that the normal structures are not called as abnormal. For example, the spheno-occipital and the synchondrosis, which are not yet ossified, may be erroneously reported as fractures. Certain mimics are also important for us to know. This is the pre-contrast T1, this is the post-contrast, and this is the T2 weighted sequence here in a patient who came with progressive proptosis. One can see that there is this iso-intense material here, and there's some surrounding soft tissue to this. And this turned out to be a mucocele because of the hyperintensity and the septated appearance of this remodeled frontal sinus. This is another example of an encephalocele. One can see there's prolapse of the entire intracranial contents here, and there's a large cystic structure. I have included this as a quiz as well. You can see that the clue to that is the convergence of the sulci of the frontal lobe towards that defect out here, and the protrusion of the brain material here, and also the extension of the PR ethmoid sleeve around it, which contains CSF-like fluid. The fibrous dysplasia lesions are commonplace and should always be addressed to and looked after. And you can see for yourself that there is this ground glass material, which is so characteristic of this lesion. It has many features to it, and the other aspect is contain more of a fibrous material than the osseous, which appears to be iso-intense on the pre-contrast T1 and shows typical heterogeneous enhancement following administration of intravenous contrast. And the rest of the osseous component does not enhance. That fibrous and osseous component on CT also can be identified if you look at carefully at the attenuation between the osseous component and the non-osseous component, which has got a slightly lower attenuation than the bone itself. So now coming to the quiz cases, I'll quickly go over. This was a case of a very aggressive appearing lesion, which had involved the sella and the suprasellar region. There were these multiple fluid containing structures here in the sphenoid sinus as well as in the nasal cavity. And this tumor was more enhancing in this location in the suprasellar system. There is this faint preservation of the clivus, which was present here. So with the destruction of the sella and involvement of the clivus, the primary aim is to note that this was actually arising from the sella. The sella is expanded, and you can see that that tumor is also related to these polypoidal mucosal lesions here, which are in the nasal cavity as well. So this patient actually presented with a Samter's triad. He had nasal polyposis, and there was this destroyed framework of the clivus from a lesion which arose from the sella. This was a aggressive pituitary adenoma. The lesion also involved portions of those polypoidal lesions in the nasal cavity as well. And there are several classifications, including the Hardy's, Knopp's, and Zurich classifications for grading the extent of the sellar tumors and also for aiding the surgical approach. The second case was a typical case which had shown on the pre-contrast and post-contrast images. I'm sorry, this is a pre-contrast image which shows that there is this this T1 hyperintense material in this large lesion, which is actually having both cellular as well as retrocellular component. This was a commonplace craniopharyngioma. One can see in this SWI sequence, which I provided, that there were areas of T1 hypointense signals, which were seen in the more solid component of the lesion. There was preservation of the pituitary gland as well here on the post-contrast sagittal images, which was a clue that this was a craniopharyngioma. So craniopharyngiomas usually are of two types, adenomatous and papillary type. The adenomatous are usually seen in children, and the solid components of the lesion may show areas of hemorrhage or calcification, which are important to distinguish on the SWI sequence. This was another aggressive tumor of the anterior cranial fossa, and the clue to the diagnosis was on the cystic space on the intracranial aspect of the lesion, which was having a large sinonasal component to it. This was the CT scans which was given to you, and it had shown this. There were these areas of erosions of both the cribriform plates here. This was an olfactory neuroblastoma. As you know, they are MIBG avid, and they can have distant metastases. They have a binodal presentation, and the peritumoral cysts are seen in the intracranial aspect of the lesion. This is another example of a post-traumatic encephalocele. Here, the encephalocele is very clearly demarcated as a CSF fluid containing a pouch here, and the confluence of these of the prolapsed appearing frontal lobe sulci are noted on this study. The CT was provided to let you see that this appears to be a long-standing congenital variant of encephalocele, not a post-traumatic one, which was shown in the part of the lecture. So this was the second most common type of cephalocele. The most common is, of course, the occipital cephalocele, and one would require multi-layered reconstructive surgery to see the defect. This is another study which was there, which had shown some enhancing. There was this bilobe T2 hyperintense lesion here. There was an enhancing area here, and there was another channel which was going towards the crista gela here. So this was actually a nasal dermoid, but they could be an extension of the nasal dermoid through a very tortuous channel here, but this was not really found, but it was reported as a nasal dermoid because of the location of the lesion and also because of the presumed intracranial channel. This was a study which showed bilateral naso-ethmoidal encephaloceles. There were large areas which were there. This is a congenital condition, so we can see that there is hardly any bone bridging the ethmoid sinus, and the entire brain herniates together with this cystic component with possible structures from the PR ethmoid. And there was this large component on this other side as well, which was actually emanating from somewhere in the lacrimal fossa. Sorry, from the region of the lacrimal duct area. And this was the bilateral naso-orbito-frontoethmoidal. The bilaterality was important here. And one to recognize these craniofacial abnormalities is a challenge, and also to operate. And that's why I had used that as an example. This was another lesion which actually was given as a companion case to show the lesion in the region of the nasal, in the glabella and the dorsum of the nose. There was a suggestion of a channel here, or maybe involvement of the non-ossified crista geli. This turned out to be a nasal glioma, which is a hematoma, and usually it contains dysplastic cells without any intracranial extension. This was a more older patient. As you can see, he's got a very thick skull. It is not a child, and it had shown these defects in the petrous apices and contained CSF-like material, and there was no enhancement. There was the contents were not showing any signals on the axial T2 beta sequence. These are very commonplace lesions. These were petrous encephaloceles, which are seen here, and usually they are considered to be some sort of ectasia of the Meckel's cave, and then they are that dural ectasia just goes inside and forms these particular these herniations of the CSF containing spaces. The companion case was this apical lesion, which was hyperintense on T1 weighted sequence and remains hyperintense on post-contrast and T2 weighted sequences. And it was not showing any impeded diffusion. And this was a classic cholesterol granuloma, which contains portions of cholesterol crystals and methemoglobin. And it shows no restricted diffusion, and a hydrated mucocele and an ICA aneurysm are in the differential. As opposed to this patient who had shown this cavitatory lesion in the middle, in the petrous bone, which erosions to the skull base, including portions of the sinus plate on the sagittal reconstructed images. The clue here was this the mastoid cavity here, and this was the impeded diffusion seen in the material contained within the petrous bone, and this was showing minimal enhancement here on the um, post-contrast images. So these were recurrent cholesteatoma in this patient. The idea was to show the restricted diffusion with whatever amount of material you have in the operated case. So the chances are that this was a recurrent cholesteatoma. This was another patient who had shown this lesion in the petrous bone, which had shown a spiculated osseous component here. On the pre-contrast, it had shown some sort of a fluid there. There was a destruction on the CT, and this was the post-contrast imaging showing that there was this enhancement there, and there was this vertical piece of bone, like a tree-like front coming in the center, and this should shown no true uh, uh, no true um, impeded diffusion. This was the SWI sequence or a T2 star sequence, which had shown that bony tubular structure in the center and these multiple areas of hypointensity. This was the endolymphatic sac tumor. It was the moth-eaten appearance of a temporal bone and central calcification spicule is important, and that was the clue to this case. This studies showed a excavating region in the clivus. So oftentimes you see them, you don't know what to think about it. They don't enhance. They appear to be hyperintense on T2 weighted sequence and isointense or even hypointense on flare, which resembles CSF. Um, there was no enhancement in this example. The lesion appears to be very well punched out. This was ecordosis physalifora. It's supposed to be a variant of chordoma by some places, some pathologists, but it's a benign lesion and possibly represents hamartomatous notochordal remnant. I showed two other cases of some weird looking canals in the sphenoid bone here in the center, which was very well corticated. And in this instance, where there was a vertical channel going towards the inferior to superior aspect of the clivus. These named canals are called the median clival canals, and they are variants of the notochordal remnants, and they are it's considered to be a variant anatomy, and it should not be mistaken for lesions. Thank you for your attention. I hope that this was a informative talk. I know that this is a very wide topic, but then hopefully